I'm Aundrea Cline-Thomas with ISPOR TV. Collaboration is key in the HEOR community. Grace Hampson is here to discuss how key stakeholders can learn from each other. Thank you for being here.
It's a pleasure.
Yeah. So you suggested that health economists should learn from environmental economists. Why? Explain that.
Thank you. So we know that climate change is having an impact on health and on healthcare systems. So it's projected that by 2050, climate change will have been responsible for nearly 15 million deaths and will have cost our healthcare services around the world over $1 trillion. These are big numbers. In turn, healthcare systems are impacting climate change. Healthcare systems are responsible for between 4 and 5% of global emissions. Within that, it's estimated that around a quarter, 25%, is from pharmaceuticals. So this is a really big challenge. Fortunately, there are various policy levers, policy tools that we can use to try and incentivize manufacturers and innovators to develop greener innovation, more environmentally friendly products, or products that will have a beneficial impact in environmental terms on the healthcare pathway. So, for example, we have financial incentives, so tax credits, subsidies, carbon pricing mechanisms, that sort of thing. There's reputational incentives, so ESG, CSR ratings, they influence how stakeholders and investors might behave. We have regulatory incentives, things like certification and environmental standards. We have collaboration, which is to do with industry partnerships and knowledge sharing. And then we have procurement and pricing and reimbursement incentives, which is where HTA fits in, and HEOR, part of the conversations that we've been having at the conference. So one job that we have as economists is to figure out what is the optimal combination of those incentives that's going to work to bring about that change that we so desperately need to see. And as part of that conversation is a question around whether HTA should be expanded to include environmental outcomes. And this is the part where we really need to listen to our colleagues who already have more experience in this. So environmental economists have been thinking about how to model environmental impacts for years, much longer than we have. They've experienced those challenges, overcome them, and have tools and techniques that we can learn from if we really want to appropriately value those impacts. So, for example, this morning in a session that I was moderating, Professor Ben Groom, who's an environmental economist, was explaining how we might need to change how we approach discounting if we want to make sure that we adequately capture those environmental effects. So there's certainly things that we can be learning from these experts. I don't want to lose sight of the fact that HTA is still just one of those incentive tools that we can use. So perhaps there's also other things we can learn from them around how those other types of incentives can be well designed and well structured in order to get the most out of them.
So have us conceptualize, if these two groups were able to come together and collaborate, what could that look like in certain sectors? Is there an example of what that could look like?
Well, I think the first step is having the conversations like we are today. So leaning into the methods and the techniques and the tools, having conversations and trying to work together. I think, so to go back to the discounting example, there's a lot of debate in the literature and amongst academics and people interested in this space around what is the most appropriate discount rate that we should use for these effects. What we don't have is consensus on that. So health economists, environmental economists, and economists more widely, it's a question that we need to tackle together because the discount rate is not something that you change per policy. It's something that impacts a huge range of policies. So that's one area where this could really have an impact.
So how can this help with expanding the definition of value and embracing the concept of whole health?
Yes, thank you. That's such a good question because whole health challenges us to think more broadly about health and think about the wider social determinants of health as well as about healthcare. And one of the key pillars of that, those social determinants of health is the environment. That is the natural environment. It's also the built environment, but the natural environment really does have a really key role to play here. And I don't think we can't move towards a concept of whole health without really investing in and thinking about the impact that the environment has on healthcare and that healthcare has on the environment.
Sofie Berghuis now joins us to continue the conversation. So what are the gaps in data used in HTA assessments, and what challenges does that pose for decision making?
That's a really good question. I think what we typically see when we are developing clinical trials, for example, to bring new medicines to patients, then it's not really possible to do that for all the patients. So you're always left with a package of evidence that's not supportive of every individual patient that you may come across over the world. So at some point, it's important to be able to transport the results that you find in the trial to a broader population. And there's definitely methods to do so, but these methods may directly also introduce some uncertainty around the decision that's then going to may be made. And that's obviously a challenge for the payers that we're discussing this with. And I think if I had to summarize it from my perspective currently, that's the biggest challenge that I would see at this point in time. How do you do that? How do you make sure that people are convinced that these methods that you then apply to extrapolate these results, to transport these results, are actually valid and giving you the right angles for the decision making?
Is it because because the data hasn't been correlated in that way in the past, or is it because there's something faulty in the data?
Yeah, that could be. That's it's not the faulty thing in the data, I think, but if you don't measure it initially in the trial, then it's super difficult to bring these results to a population where you want to say something about it. So, for example, if we investigate cancer patients and you bring in patients that are super fit, whereas in the real world, patients may be a little bit less fit, how do you then make sure that you transport the results of the RCT to also a broader real world population, and that these methods actually give you confidence in the results that you find then? And I think the confidence, especially also when it comes to how transparent are these methods, how well known are they by all the HTA bodies, that's still something that we may be able to improve in with all the HTA bodies.
Is there technology that can be used to assist?
Yeah, I think we still mostly stick to individual patient data and comparing that data to patients that we see in the real world. But there have also been developed a couple of new methods that try to do this on aggregated data, and they have demonstrated, they were just presented today, to perform super well. So that may be a future direction to explore whether that could bring us some additional evidence and some additional things that we could use for these decision-making processes.
So if this data can be used, what would the end goal be? How would it bolster what we understand, let's say, about cancer or any other ailment?
Yeah. Well, for example, if you would take an RCT that likely is not running in the Netherlands, where I'm from, because that country is super small and that makes it difficult to attract a big patient pool. So patients sometimes come from the Netherlands, but that's just a small pool. And then you have Dutch patients, France patients, US patients in the trial that bring you a result. So how do you make sure then that when you see that result, that it also applies to the Dutch patients? And by using these methods, you can actually demonstrate and give confidence that actually what you have measured in the bigger population also applies to the smaller population, by just finding the balances between patient characteristics, by identifying confounding effects that you may have seen in the study, and all kinds of statistical methods to do so.
There's so much more that we can learn with the data sets that we have.
Yeah, and I really hope also that the EU HTA is also something that we learned super much about during this conference. And what we expect from that is that many PICOs, so the comparisons that the countries want to see, where you basically define which patients with which intervention and which control you want to see at which outcomes. And if all the countries can do that, you can imagine that lots of these PICO questions come up, which actually forces us to think broader than just the RCT, because the RCT on itself will never be able to cover all the evidence gap that's needed to make the decision to reimburse new products, for example. So that's definitely, I think, a trigger for us to further do that.
Yeah. Thank you so much for your insight. We really appreciate it.
You're welcome.
And I'm Aundrea Cline-Thomas with ISPOR TV.